Okay, hello and good afternoon, everyone. I'm just waiting a few more seconds until people are joining, and then we will start this webinar. Good afternoon again. My name is Michal Steinberg. I'm a pulmonologist from Haifa, Israel, and a member of Embark Management. And this is the last webinar in the Lessons in Bronchiectasis webinar series. And today's topic is radiology of bronchiectasis. And we have two wonderful and very well-known speakers, and I will introduce them in a minute. They are Tiddens and Pierluigi Ciet. But before I do this, I want to turn your attention to the translation options that we have in Zoom. To activate this, you need to click on the show captions below, and then on the right arrow, and then a menu will open. You have to leave the speaking language in English and select the target language that you want. If you don't see, there's more languages in the menu. So with this, I will introduce Professor Harm Tiddens, who will then introduce Professor Ciet. Professor Tiddens is a pediatric respiratory physician, and since October, he's emeritus professor at the Erasmus Medical Center Sofia Children's Hospital at the Department of Pediatric Pulmonology and Radiology. Since 2022, he's the Chief Medical Officer at the AI company Tirona, which is focused on image analysis of the lungs. In his academic career, he focused since 1991 on the relation between structure and function of the lung in health and disease. He acquired unique expertise in radiology with a focus on chest CT, chest MRI, and image analysis. He has ongoing worldwide collaborations with leading groups in the area of chest CT and MRI and outcome research for a wide range of pulmonary diseases. I'm sure it will be a fascinating webinar. Please post your questions in the Q&A and in the chat. We will look out for them, and there's also polls. And with this, I will hand over to Professor Tiddens.
Thank you very much, Michal, for introducing. And now it doesn't move, so I want to right away. So there it goes. So thank you very much for this invitation. So today we're going to address the radiological diagnosis of bronchiectasis. The imaging part will be discussed by Pierluigi Ciet. And Pierluigi, I know him a long time. He was a former PhD student, then moved into a postdoc position. During his PhD work, he acquired his board certification for thoracic radiology at the Beth Israel Hospital in Boston, which is part of Harvard Medical School. During his, so he became a staff member and also acquired his certification for pediatric radiology in Erasmus Medical Center. He runs his own research. I forget, he's also now associated professor at Cagliari in Sardinia. He is leading now his own research group. His focus areas are advanced chest MRI imaging and chest CT imaging. And so he will discuss the, let's say, the radiological diagnosis of bronchiectasis from as it is done now, still in daily practice. Next, I will discuss the new insights that are given to us through the AI analysis of the images. So Pierre, please go ahead.
Well, first of all, I would like to thank the ERS for the invitation to this webinar and Harm for the introduction. So Harm, you can go to the next slides. These are my disclosure, nothing related to this talk. And this is the overview of my presentation. So I will go through the different techniques. I left out MRI because I thought it was not so used in the daily practice. And so I will start with the chest radiograph, and then I will move to the chest CT, which is still the most sensitive technique to assess bronchiectasis, going through the problem of the volume standardization to assess the severity of bronchiectasis, the advantages and disadvantages of using CT, and then the issue of the dose with the introduction of the photon count in CT. Okay, next slide, Harm, please. So let's start by talking about the detection of bronchiectasis on chest radiograph. Typical sign of bronchiectasis on chest radiograph are related to the thickening of the bronchial wall and by the filling of the airways by mucus. If you click again, Harm. And these are what is normally described by the radiology. So those opacity, or toothpaste opacity, or Glover in finger opacity, which actually are a progressive filling of the airways by mucus. The thickening of the air wall presents on a chest radiograph as sort of tramline shadows, which are to be seen in the perihilar region, as you can see in this patient with cystic fibrosis. I cannot use the pointer, but you might see that around the hilar region, you have some double contours, and those are representing area of bronchiectasis. Next slide. What is the problem of the chest radiograph is that in general is a really low sensitive technique. And this is an example of that. This is a patient with, again, cystic fibrosis. And I will ask to the audience if they see any sign of severe bronchiectasis or mucus plugging or post-obstructive atelectasis or consolidation in the chest radiograph. You cannot answer, but you will probably don't see or don't mention anything, but Harm, if you go to the next slides, this is the CT scan made on the same subject on the same day. You can see that there are some area of severe bronchiectasis, mostly in the dorsal part of the right upper lobe, which is an area that on the chest radiograph is quite difficult to assess because it's the area that is between the clavicles and the first rib, is also known as the hidden part of the chest radiograph. Click again, Harm. And for this reason, is sometimes difficult to spot these changes, to determine new changes, and also to identify also large area of bronchiectasis, like in this example. Next slide, please. So let's start with the first question. To acquire a chest CT in a appropriate subject, lung volume should be optimized for the following reason. And the first option is the ratio between the outer diameter of the airway and the adjacent artery for the diagnosis of bronchial widening, bronchiectasis, is highly dependent on the level of inspiration. According to the Lara principle, the lung volume should be optimized to maximize the diagnostic yield of the radiation given, to optimize the sensitivity and accuracy to track these changes in structural lung anomalies, or the last, all of the above. Please vote. We have 84 participants, which is a good number to be a summer period. Do we have the results, or are still voting probably?
Yeah, so probably good to give a few seconds. And also, if people want to place comments or questions in the chat, please do so.
Okay, I see gladly that the majority of the people that answer to the poll choose the last one. Indeed, all the 3 points are correct. And then we will go through this. Next slide, Harm.
Oh, wait, I have to click on it again. Yeah.
Yes. So when we do imaging with CT, and here I'm starting by talking on the pediatric population, we make a distinction between patient that can follow instruction and patient that cannot follow instruction. So patient that cannot follow instruction for the pediatric population are most of the time children below 5 years. In that case, the CT scan will be acquired in free briefing. If you click now, Harm, yes, again, yes. This is an example of a free briefing CT. So it is the, let's say the consequences of doing a free briefing CT is that you will not have a full inspiratory, full expiratory scan, but you will be at the end of a quiet expiration. So at the level of a functional residual capacity. In our hospital, since long time, in children older than 6 years, we perform the CT scan with a speedometer to standardize lung volume. In this case, again, Harm, click again. You can see how by using the speedometer, you can really reach in inspiration the total lung capacity, and in expiration the residual volume. This helps in the interpretation of the images for 2 reasons. First of all, the images are sharper without artifact. The patient is trained to perform this maneuver, so is familiar with what he is supposed to do during the examination. At the same time, the size of the airways that we're gonna measure and look at is in the full inspiratory and expiratory condition that I will show you in the next slide why it's important. Next slide, Harm. So the definition of bronchiectasis based on the Fleischer Society is that the airways are larger than the adjacent pulmonary artery. But if we do not consider the volume of the lung parenchyma, we might be fooled by the fact that in expiration, the airways tends to collapse, so they will be smaller of the artery. Though in that case, we will not mention the presence of bronchiectasis. So that's why bronchiectasis are normally assessed in full inspiration. That's why the full inspiratory scan is really important. Next slide, Harm. So moving to the advantages of using CT, of course, is the technique with the highest sensitivity. Standardization is feasible. Our group have made an amount of work in standardization of CT protocol for CF patient within the ECF Society. Is a technique really fast, accurate, comprehensive, can be done in any condition, even in small children can be done without anesthesia, and can provide quantitative data. Then Harm will show fantastic images about the production of quantitative data. One of the issues of using CT, not for the adult patient, but mostly for the pediatric population, is that there are radiation. Next slide. So how much is the radiation using the CT scan? Almost, I think, 8 years ago, yeah, I think it was 2016, 8 years ago, we made a publication where we quantified risk of getting cancer by using a CT protocol from age of 1 to age of 17 in CF patient. We know that bronchiectasis is one of the main features in CF, so we try to quantify this risk and to put this risk in perspective with other risks that every person has. So first of all, person has a risk of dying for cardiovascular diseases and accident is almost 75%. There is a risk of 23% to get cancer not related to CT scan, but just by background radiation. And if you move in an area where the background radiation is higher, for instance, there is a difference from the Netherlands and Italy in terms of background radiation, you will have an extra 0.7% risk of getting cancer. So the risk of this protocol that includes in total 9 CT from age of 1 to 17 is 0.2%. So there is a risk, but the risk is quite small compared to other risks. So it should be put in perspective, taking account that the CT provides vital information for the management of these patients. And long time ago, has been said that maybe in the future was possible to produce a CT scan with a dose comparable to a chest X-ray. And next slide. And this is happening because different groups, like the group of Cork in Ireland, has developed protocols with really low dose, ultra low dose. It's not correct to mention ultra or hyper low dose because the dose change every 3 to 5 years according to the DRL. This is the common practice in radiology, but in general, this image is what is showing you is that it's possible to obtain a CT scan with enough image quality with 4% of the dose of a standard dose in a CF patient. This is an example where you can see clearly the huge bronchiectasis in the upper lobes. You can see the bronchial thickening. You see also some peribronchial consolidation. Next slide, Harm. But last but not the least, for whoever is lucky enough to have a photon count in CT, This is a new technology that's been introduced in 2021. It's a new type of CT scan, completely different technology and hardware that has two main advantages. First of all, the resolution is 4 times higher than a standard CT scan, so you can obtain images of 0.2 millimeters instead of 1 millimeter. And the second main advantage is the dose reduction. Because of the technology, it's possible to reduce the dose with reduction that, based on preliminary results, can go up to 60%. So what kind of image quality can we get? This is an example, again, from a CF patient. I'm using always CF patient because it's one of the largest population we have in our hospital. The first image on the left is the image taken by a standard CT scanner. They also known as AIDCT, that stands for Energy Integrating Detector CT. And the other 3 images are taken from a photon counting detector CT. You should already realize that by comparing the 1 millimeter examination, the noise in the photon counting CT scanner is much lower. If you look, for instance, on the soft tissue here in the axillary region, on the right side, you don't see that grain aspect of the first image in the left upper corner. But the beauty of this technique is that we can use image of 0.6 or 0.2 millimeter. And if you start to look in the most peripheral part of the lung parenchyma, you start to see small bronchiectasis or small cysts that actually are not visible on the standard CT scanner. Next slide. So now I do a step back. I give you a little bit of background about the dose, and I will give you sort of a common lexicon when you have to describe bronchiectasis on a CT examination. So on CT, we have 3 major terms. We talk about bronchial widening, bronchial wall thickening, and mucus plugs. Those are also known as direct sign of bronchial pathology. Next slide, Harm. We make also a distinction between central and peripheral bronchial widening. So you have central and peripheral bronchiectasis. The peripheral part is normally the part of the lung that is considered within 2 centimeters from the pleural space. And here you have 2 examples of mild or tubular bronchiectasis, where on the left side you have a central mild bronchiectasis. If you can click again, Harm. Yes, again. And you have the typical radiological sign, it's called the signet ring sign, where you have the enlarged airway with the pulmonary artery on the top. On the right side, you have an example of a peripheral bronchial widening, where you see airways within 2 centimeters of the pleura. Normally, you shouldn't see it. Next slide. So when you talk about bronchiectasis, you can also try to give a severity of the bronchiectasis. And there are 2 ways to do that. One is to say that the bronchiectasis are tubular, varicose, or cystic, and it's the same things of saying that they are mild, moderate, or severe. And this is based on the size of the airways compared to the artery. So from 1 to 2 times the size of the artery, you will have mild bronchiectasis. Between 2 to 3 will be moderate. And if the size of the airways is 3 times higher than that of the pulmonary artery, then you have a severe bronchiectasis. Regarding bronchial wall thickening, you have also here a different definition. The range of, let's say, severity that is described in the literature to define a diagnosis of bronchial thickening range between 33 to 50%. And this percentage refers to the size of the bronchial wall compared to the size of the pulmonary artery. What does it mean? It means that if the wall of the bronchial wall is thicker than 33% of the diameter of the pulmonary artery, then you have a bronchial wall thickening. Okay. Also, in this case, you can define central and peripheral bronchial wall thickening. On the left side, you have an example of a severe central bronchial wall thickening, and on the right side, you have an example of peripheral bronchial wall thickening. The third direct sign of bronchiectasis is the presence of mucus plugs. So the enlargement of the airways determines a reduction of the clearance of the airways. And then we'll have two type of pattern of mucus plugs. If the mucus plugs is in the central airways, we will have those tubular structures that you see in the image in the right upper corner. And these are, for instance, to be seen in a patient with ABPA, with allergical bronchopulmonary aspergillosis. If the filling of the airways is happening in the most peripheral part of the lumbar parenchyma, so filling really the centrilobular airways of the secondary lobule, you will have two patterns. One is that is known as rosette pattern, which are small centrilobular nodules, or the filling of the most distal airways, so the bronchioles, and we will have the trim bud pattern that is sometimes described by the radiologist in the reports. You see here in the image below. Last but not the least, the indirect sign of bronchiectasis. So we have to realize that large part of the airways are not visible on a CT scanner. And this is because of the resolution. So if you are having a CT scan with an isotropic resolution of 1 millimeter, your maximum size that you can detect is around 2 millimeters. This is with a standard scanner. So some airways are not visible, but they can be affected by small airway disease. So then we will have indirect sign of small airway disease. And here we define three terminology. One is the mosaic attenuation or mosaic perfusion, which is a non-specific term, and it should be used only if we have a single examination, so not when we have an inspiratory and expiratory scan. And what does represent is this patchy appearance of the lumbar parenchyma, where we will see hypodense and normal density lumbar parenchyma, with that it is actually suggesting a small airway disease or a perfusion problem, but that cannot be clearly differentiated. If you have an inspiratory and expiratory scan, where the inspiratory scan looks completely normal, and expiration you have the same patchwork regions, that might be a case of air trapping. That is to be seen only in the expiratory scans. You will not see change in vessel size in those hypodense region. And interestingly, that can be also automatically segmented using the Auschwitz unit density. This is mostly for adult subject, where any voxel within the lumbar parenchyma with a density below minus 150 up to minus 950 will be defined as air trapping. Everything below minus 950 will be defined as emphysema. If the patchy region are visible in inspiration and expiration, and in those hypodense areas, we also notice that the vessels are smaller and thinner compared to the area that they are looking normal. That might be a case of vasoconstriction, chronic vasoconstriction, that can also happen as an effect of a chronic reduced ventilation due to the hypoxia vasoconstriction reflex of the lung. And this is a way to make that distinction. And an example of that might be a patient with bronchiolitis obliterans, where in that case, you will have this hypoperfusion pattern with reduced vessel, bronchiectasis, bronchial thickening, and sometimes mucus plugs. So this is my last slide, and I will give the word to Harm. So in general, for looking at bronchiectasis, they can be seen on a chest radiograph, but only, I would say, severe bronchiectasis. So I'm still wondering what is the use of this technique for, let's say, long-term follow-up of patients with bronchiectasis. CT is the most sensitive technique. It's important, if it's possible in your hospital, to implement volume standardization, but that optimize the quantification of the severity of the bronchiectasis. And the issue of the dose is less and less a problem, especially for the introduction of ultra-low dose protocol, and possibly with the photon count CT of a hyper low dose protocol. That was my part.
Well, thank you very much, Pierre, for an excellent, concise presentation. Mikhail, I don't know if there are any urgent questions at this stage. We have at the end, we will have time reserved for questions and answers. But
I see there's one in the chat, and I think it may be a good idea to pause and read some questions now. Oh, sorry, no, it's just about the video resolution. But I have a question that I wanted to ask both of you. It's about contrast and what is the role of contrast medium infusion, and does it differentiate and is it helpful?
Pierre, you can answer that one.
First of all, we know, and these are unpublished data, hopefully published really soon, is that if we use contrast, the size of the airways looks bigger. So we recently analyzed a data set of CT scan made with contrast. We're using advanced tool that Harm will present in the next part of this webinar. So you have like a sort of artificial increase in size of the airways. In general, for assessment of bronchiectasis, is not so important using contrast. The contrast can give you some help if you want to make a distinction between the mucus and the wall, because the mucus is not taking contrast and the wall is taking contrast. So in case of circulation, it's possible to make that distinction, but let's say routinely it's not used.
Okay. Yeah, I would agree with that. Contrast also includes, it's invasive, you need access, penis access. There's always a small risk related to it. So clinically, we don't use it routinely for at least bronchiectasis patient, except of course when you have bleedings, then you might need it. Okay, so I want to move on. So I'm going to focus on image analysis. I was already introduced in terms of my bio CV. These are my conflict of interest. It's my dual, let's say, affiliation, which is the biggest conflict of interest. So what I'm going to discuss, this one, that's weird. Okay, this, I didn't know this was going to pop up. Okay, so I'm first going to discuss, let's say, how we identified structural changes which are relevant to assess in bronchiectasis patient, and we used a sensitive morphometric approach that was initially developed for cystic fibrosis. Then we move into the actual measurements of airway artery, bronchus artery dimensions, and the automation of it, and that results in outcomes which actually can be used for diagnosis, but also for follow-up. I will very shortly touch upon what Pierre already discussed, these low attenuation regions, which often define as trapped air, but what he already mentioned, it is a combination, can be a combination of trapped air and or hyperperfusion. And finally, I will discuss mucus plugging, what we can do with that. So first of all, there are many, many lung diseases, and the thing they have in common are actually structural changes that we would like to measure. That is the bronchial widening. So Pierre uses the term bronchiectasis, but a radiologist, when you ask about bronchiectasis, means those varicose, really widened airways. And I think it's good to distinguish the widening and the thickening. They're two important components. And when you talk about bronchiectasis disease, is a patient with bronchial widening, thickening, but also with symptoms. So mucus is a common feature, and those low attenuation regions on expiratory scans. So these are the kind of things you would like to measure on a CT scan. So this is the report that Pierre still generates, let's say, on a daily basis. And the thing to keep in mind, it's of course a judgment, and Pierre is a real expert, so I trust him. But of course, his training can be different than a colleague elsewhere. And on Monday, he might do a different job than on Friday. It's a subjective evaluation. It's expert opinion. And therefore, we know already from multiple studies that it's actually quite poor reproducibility of those reports. And most importantly, even though Pierre mentioned these ratios, there are no objective measurements executed. And especially that means that the extent is not really captured. And the sensitivity to detect abnormalities in smaller airways is questionable. So I will discuss this in more detail. So it's a little bit like a clinical chemist evaluating the hemoglobin level in blood by looking at the tube against the light and guessing, well, you know, I think it's an 8, maybe 7.6. And we know nowadays that the laboratory in the hospital, they're highly automated. There's a lot of work done on standardization and quality control. And at the end, the clinical chemist is responsible for this daily quality control that the correct answers are giving to the clinicians. And I think we're moving for radiology in the same direction. So my question to you is, and please all respond, an important component of bronchiectasis is widening of the bronchus relative to the adjacent pulmonary artery. In clinical routine, the radiologist will recognize an airway is widened when the ratio between the inner diameter of the bronchus and the adjacent artery is above 0.8, if the ratio is above 1, or of the outer diameter of the bronchus and the adjacent artery is above 1, or the ratio between the inner diameter of the bronchus and the adjacent artery is above 1.5, or the ratio between the outer diameter of the bronchus and the adjacent artery is above 1.5. And you can also answer, I have no clue. Please, your answers. And drink some water in the meantime. So I think the time for thinking is up. The results. So you see actually the results a little bit all over the place. The highest scores, I have no clue. And that's kind of interesting. And then I have to click again on this. So, oh, it doesn't want to move. Now it moves. So we asked exactly this question. What is actually the ratio? And so Jennifer Meerberg, one of my former PhDs, she did a systematic review, extracted over 4,000 abstracts, read over 900 full text publications, and included 120 studies to actually understand what are the different ratios being used and how they are measured. She ended up with 42 different scoring methods, and the conclusion of that paper is there are actually no validation study for any cutoff value. Basically, any answer was correct. And to use bronchiectasis outcome measure in the future studies, we summarize that it should be validated and age-specific cutoff values should be generated. So this is the way how we work as clinicians. We work as much as possible with numbers. That means functional tests, lung function tests, they generate numbers, even quality of life questionnaires give us a number. The laboratory gives us numbers, and microbiology gives us the assessment of specific mycobacteria and also of microorganisms, and also, well, semi-quantitative estimate of the number. And of course, for chest CT, we want to have numbers, which makes it easier to manage patients. So this is why we developed this morphometric system in cystic fibrosis. Basically, you take a stratified random sample of all the slices of a chest CT, you put on each side a grid, and then a trained and certified observer will determine for each grid cell what is the content of that grid cell, and it works the way down in hierarchical order of this list that you see on the left. If it's atelectasis, bronchiectasis plus a mucus plug, bronchiectasis without a mucus plug, if that is not the case, air wall thickening, if that's not the case, mucus plugging, ground glass opacities, and works the way down to, well, it contains a normal airway or normal parenchyma. And it gives a very sensitive readout of the volume fraction of that structure abnormality for the whole lung. You do that on an inspiratory scan, you can do an expiratory scan as well to assess this volume of low attenuation region, or what's often defined as trapped air. So using this system, Angelina Peters she scored in random order 84 bronchiectasis patients who participated in a phase 2 study, which was part of the IABC consortium. And so what you see here is the patients sorted on their total volume of abnormal lung tissue. And you can already see the enormous heterogeneity. So all the patients are diagnosed as bronchiectasis, but on the left you see a patient who has more than 40% of lung volume occupied by abnormal lung tissue, while on the right there is a patient who just has a few bronchiectasis, but actually nothing else. So there's substantial heterogeneity in the extent of the abnormalities. The other thing which you can see is a lot of yellow representing actually the volume fraction occupied by mucus. So that is clearly a part of the important structural changes. This exercise was repeated by Angelina on the EMBARC registry. We collected over 800 CTs, and of which she scored 524 before she ran out of time. And you see exactly actually the same kind of heterogeneity in severity of the EMBARC population. Only now you see on the right, there's even patient with 90% of the volume is highly abnormal. So substantial heterogeneity in the kind of structure changes and in the extent of the abnormalities. So now my next question, and Pierre already touched a little bit upon that, the number of bronchus artery pairs that are on average evaluated by a radiologist or by you as a pediatric pulmonologist or pulmonologist to diagnose bronchial widening on a routine chest CT of a 30-year-old man with severe asthma varies mostly between 0 and 20, 20 to 100, 100 to 300, and 300 to 1,000. Or again, I have no clue. I'll give you some time and just do what you intuitively think is the number. Don't start counting. Okay, so I think time's up. Let's look for the result. Many have no clue, very good. And you see the answer is widespread. And actually at the ERS and ATS, I asked a lot of people, radiologists and pulmonologists and pediatric pulmonologists, how many airways do you think you evaluate on a scan? And mostly say between 20 and 30. But how many airways there are actually? And this is a fantastic study by Horsfield, who did a cost study of a man who died and put in resin and then really counted the length and diameter of every visible airway. And nobody ever repeated that. This is basically the ground truth from which we have to understand how many airways there are actually in the lung. And in the range that you would evaluate with a CT scan, actually, he would come up from this study, it would end up with a number of 789 BA pairs, bronchus artery pairs, in the range from 3.5 to 2 millimeter. If you take the range of the terminal bronchioles, there are more than 7,000, which you actually cannot see. And if you go all the way to the distal respiratory bronchioli, even the total number is 223,000. So on a CT scan, we see actually only a fraction of the airways that are present. Anyway, that's still a high number. So one of my PhDs, it was V and Kuo, we wanted, and also based on this systematic review, we wanted to generate ground truth of the dimensions of the bronchus and artery pairs on a CT scan. And she used software to measure cross-sectionally from the longitudinal axis of the airway, the inner diameter, the outer diameter of the airway, and of the adjacent artery. And from that, she computed the various ratio using the outer airway artery ratio, inner diameter artery ratio, and the wall thickness artery ratio. And this is the results. And this is a complicated slide. I will lead you through it. So on the horizontal axis, you see the segmental generation. So number 1 is the subsegmental bronchus, number 2, the subsegmental bronchus, and you move all the way down to the 12th generation. On the vertical axis, you see the ratio between the outer diameter of the airway and the adjacent artery. And she measured 12 control subjects and 11 CF subjects, CF in pink. So that meant she did more than 11,000 measurements. And it took her on average 1.5 day to 5 days to do the analysis of 1 CT, which meant she was 3 months, she was drawing circles, she was dreaming about it. Clearly, this is not feasible in daily practice. However, it shows that even such in these small numbers, there was a highly significant difference between the ratio in the normal subjects and in the CF subjects. So you see that the ratio in controls remains constant throughout the bronchial tree, and after the 7th generation, you don't see any more pairs. So there is nothing to see anymore. While in CF, you see that the ratio goes up with each generation, and then above the 7th generation, then the numbers go up and up and up, because in CF, you still see widened and thickened airways, and therefore they become visible. So clearly that is not feasible in daily practice, and therefore the system has to be, was automated, which meant this BA software automatically segments the bronchial tree, and then for each airway segment, identifies using another algorithm the adjacent artery, and then computes from that automatically at multiple locations the inner diameters, the outer diameters, and the wall thickness. And it does so not only for the airway, but also for the artery, so to generate all those dimensions. From the, So that is the LongQBA software. So it's sensitive and accurate. So what it measures, it is accurate, and it almost includes all pairs that are actually present within the range of the sensitivity CT scan, and it automatically analyzes it in an acceptable time frame. But I already stressed that's only a very small fraction of the airways that are in the lung, and Pierre already mentioned for that you need also to use the expiratory scan, ideally the residual volume, and then you can, there's different software also developed by Tirona, which now can compute the volume fraction of the lung occupied by the low attenuation region, and also can differentiate between airways that of a lung region that shows trapped air, so normal parenchyma, but air trapping, and also identify regions of emphysema with and without trapped air. And this is the way it looks. So you have the inspiratory scan, expiratory scan, and it uses using registration technique to identify those low attenuation regions and distinguish between trapped air and emphysema. So let me show you an example how this LongQBA, how for an individual that can work out. So this is one of the patients from the EMBARC registry. 415 BA pairs could be identified in subsegmental generation 1 to 10. And you already can see from the segmental bronchial tree, if you go to right lower lobe, you see there's one airway that moves all the way into the periphery. That already tells you there is bronchiectasis there. There's widening of a peripheral airway. So it looks abnormal. And if you look at the slice above it, you see there are some airways which are actually widened and thickened, but you don't see so many airways. And there, of course, there are a lot of airways to evaluate. So with this software, now you automatically can evaluate 96% of the airways that can be detected on a CT scan. And this shows you the histogram. On the horizontal, you see the segmental generation, again, one representing the subsegmental bronchus, and then the number per segment per generation you can measure. So 24, 56, 94, all the way up to 120 airways in the 4th generation. Then the number goes down again because you hit the resolution of the CT scan. And from that, those airways, we extract the metrics. We call it the G1-6 range, of which we extract the metrics that I'm going to show you now. So this is the ratio between the outer diameter and the artery. And why we use the outer diameter? Because it's less dependent on lung volume. It's not affected by mucus in the lumen. It's less variable and more robust structure to compare it to the dimension of the artery. So here you see that all the dots represent measurement of one BA pair. The lowest dotted line in red represents a cutoff, the 95th percentile cutoff between normal and abnormal. So for this subject, most of the data points are above this cutoff of 1.15. Actually, this 1.15 is generated by this automated system. It's not so far off the ratio of 1, but again, this is the outer diameter that is a more robust parameter. And the median value from all those measurements you see on the histogram is 2. So on average, most of the airways are widened. So what you see by the eye is just the tip of the iceberg. And Pierre mentioned the severity, the 2 or 3. And you see that actually most of many of the pairs are in that range. The upper dotted line in red represents the cutoff for the visual assessment. So what you visually can recognize without measuring anything as abnormal widened is actually 1.5. And this is the same analysis then for the wall thickness. Again, showing the cutoff is here 0.14. So most of the measurements show that the walls are thickened throughout the bronchial tree, and the median value is above, clearly above the normal range. So how does it look for the whole EMBARK cohort? And you see that over here, 615 CTs were analyzed, and on the horizontal axis, again, segmental generation, vertical axis, the ratio, and you can see that the ratio is above the dotted line. 73% of all BA pairs measured in this heterogeneous group has elevated ratios. And you see that the ratios become more abnormal to the periphery, just like what was observed also by being Kuo in the CF patients. And if you take the more conservative cutoff, then still 40% is highly abnormal. The same thing for, again, the thickening. So for an individual, how we use this for longitudinal follow-up of a subject. So here I show an example of a cystic fibrosis patient who gets a routine CT every 2 years. So this patient had a CT 2019, 2021, and then 1 year after this subject was changed to the very effective modulator therapy, the CT was repeated. So you see here the ratio between the wall area and the total airway area, and the reason why we use this metric to make it independent of arterial changes. So this is not using the artery as reference structure. The dotted line, again, is the cutoff for this metric between the 95 percentile. So you see in green that for each generation, the airway wall is substantially thickened. Then 2 years later, the patients get again a CT scan. And at that time, the patient was symptomatic. And again, for each generation, you see that the thickening gets worse. Then the patient is put on this triple therapy, and you see a substantial reduction in the wall thickness. And this is, again, the metric that we extracted, so kind of FEV1 from this BA analysis. So it goes from 0.48, clearly way above the cutoff of 1.37. It's elevated when the patient is doing poorly, and it goes even below this dotted line for after 1 year of this triple therapy. So this is how we will use in the future this analysis for evaluating the effectiveness of treatment. Mucus plugging, just to show you, has got a lot of attention because of COPD, where an association was showed between the number of segments with a mucus plug and mortality. And there is also, again, a fully automatic algorithm that can identify mucus plugs. Oh, then I should go back. And it counts the number of plugs and counts also the volume. So for me, the wall thickness is a more sensitive readout of mucus, but again, this is an independent analysis, and clearly the kind of the mucus count should correlate to what you observe from the airway metrics. So this is an example from a study by Paul McNally, the RECOVER study, with 64 patients before and after introduction of this triple therapy. And you see this was baseline before of the upper panel, before the patient was put on this triple therapy. Then 1 year later, you see most of the plaques disappeared, but there's still quite some plaques. And 2 years later, it seems to be that it even has worsened a little bit, but clearly a substantial difference to baseline. Patient 2, more modest plugs, and they totally disappear. Patient 3, modest plugs, and there's still a few left. And for the whole group, there was a dramatic drop in mucus plugging. So this metric, I think, will be used as well in the future. And this shows you for the EMBARC. So again, these are 433 CTs, 12,000 plugs were counted. This shows you the distribution of the number of plugs per CT. So there are patients without mucus plug, but also patients who have hundreds of plugs on the CT. 2 examples, one patient A with severe mucus plugging, that's really on the worst end of the spectrum over here. And this patient who is more somewhere in the middle with 43 mucus plugs. So this is another important kind of observation. And to do this manually is really very, very tedious work. So it is great that this is now automated. So I showed you how we identify structural changes which are relevant to measure. Then I showed you the automated analysis and the metrics you can extract from that. The reason why expiratory scans are important to assess the condition of the smaller airways, to capture air trapping and the consequences of trapped air, which is hyperperfusion by the hypoxic pulmonary vasoconstriction. And finally, I discuss how mucus plug analysis can help us also to define the heterogeneity of structural diseases in the lungs. And this was my last slide. Thank you very much. Then I give the floor to Mikael to discuss the
some of the questions. Yes, so thank you very, very much. This was really wonderful and really very demonstrative that there's so much more to bronchiectasis than just the ratio, the BA ratio that we can sometimes miss, and it's not really responsive. So I think in the future we'll also see in bronchiectasis, not only in CF, reports that are responsive to treatments. And I've already noticed that Pierre has been very, very busy answering, typing answers to question. Before
Can I say
we
something?
summarize,
There was one
yes.
question about MRI. Harm, do we have a backup slide about MRI, right?
I think it
Remember
should be there.
If you didn't take it out.
No, that was taken out, I think, by you.
Okay.
By you.
I thought
Not
it
by
was
me.
a backup slide, sorry.
Yeah, so maybe you can just answer live. And I thought there were also important questions about differentiating traction from bronchiectasis, which probably should be answered live. So while Pierre is answering, you can see the content of the previous webinars, and they'll all be at the site of the EMBARC. So please, Pierre.
So the question regarding MRI, there are some paper using MRI. So MRI is, let's say, especially for the pediatric patient, in several hospitals use as a technique to look at bronchiectasis. There are now sequences that allows to get good image quality. The main issue that remain on using MRI is that all the post-processing tools that Harm show are not yet developed and also are not yet validated. So you can use the MRI, but then you have still to rely to those semi-quantitative scoring system because those automatic tools are not there. Regarding the question that I also reply to the message, the distinction between a traction bronchiectasis and non-traction bronchiectasis or low inflammatory bronchiectasis, it's really about the process. So in the traction bronchiectasis, when you say traction bronchiectasis, it means that the bronchiectasis is happening because the parenchyma around the airway is pulling the airway from every side. And the typical example of traction bronchiectasis are patients with interstitial lung diseases, where due to fibrosis, the lung parenchyma becomes harder, and then it's pulling the airways and opening the airways. In normal bronchiectasis, the process starts in the airway. So it's a chronic inflammation, and then you have the enlargement of the airway. So to make that distinction, it's really about looking the other parenchymal features around the bronchiectasis to make a distinction between a traction bronchiectasis that will have sign of fibrosis, for instance, and a normal bronchiectasis that doesn't have sign of fibrosis around it.
Yes, so maybe I can add to that, because actually that discussion popped up this week analyzing a data set. There's a lot of discussion about the reversibility of bronchiectasis. And I think the discussion is confusing because how do we define bronchiectasis? So what I showed is radiologists having this varicose, very widened airways. I haven't seen those disappear. But if you now just define it as widening and thickening, we know already from CF, yeah, the thickening can reduce, and the widening probably also is reduced to some extent. But that doesn't tell us whether those severely abnormal structural changes can return to normal, and like the lung remembers the original structure, or it's just the thickened wall that is reduced in thickness, and therefore the outer diameter also goes down. And that is, so I would say in terms of traction bronchiectasis, the big difference, of course, with chronic disease like COPD, bronchiectasis, cystic fibrosis, PCD, is that there seems to be diffuse inflammation with mucosal swelling and mucus, which thickens the wall. And if you have bad luck, then it also will result in this scarring and this really enlargement of the diameter. And so that is a question that through this technique that we can answer. What is reversible? What is not reversible?
Yeah, and I also think that the accessory signs of bronchiectasis that you mentioned, wall thickening, but also mucus plugging, you won't see that in traction bronchiectasis because inflammation is not a part of the disease of the airway.
Normally not.
Yeah. So okay.
So maybe I can say something else to the mucus plugging, because of this, all of a sudden a lot of people jumped on it. So the study published by Diaz et al. Was on the number of segments with a mucus plug. And the reason why they just stopped their count on mucus plug, because it's very tedious work to identify a mucus plug. You have to look actually in 3 dimensions to really be sure that you're really sure that it's an obstruction of the lumen and not a vessel or just an airway that's bending a little bit to the left to the right. So for feasibility, they just stopped counting if they detected in a segment one plug. The automated system detects a plug, but counts everything even within a segment. Still, the sensitivity, it will not detect every mucus plug. And so this new algorithm will allow us to also see what happens to obstruction. And what I like about this is a totally different signal relative to this BA analysis and relative to this VERA analysis. And we also can look at perfusion, that it will dramatically change our understanding of the disease in the coming years. I'm pretty sure about that. Yes.
So with that, I think it's time to thank our 2 wonderful presenters. I think it was really very, very instructive and demonstrative. And so there's the table again of all of the previous webinars that you can watch on the Embark website. It's on YouTube. And with that, I will thank you all very, very much for your attention. Thank you, Professors Tiddens and Professor Ciet. And have a great rest of the day, everyone.
Same to you all. And thank you, Mikhail, again.
Thank you again. Have a nice
Bye-bye.
day. Nice summer,
Bye.
everybody.